All right. Well, let's go. So this is gonna be the first real podcast, Dave. You're gonna be first guest.
Yeah, I've never actually done this before, so.
Me either. So that's okay. So I'll introduce you and then we'll just kind of roll. Is that all right?
Yeah, that's fine.
All right. So first guest is gonna be Dave Griswold. Kind of an interesting guest, right? Dave was my first clinical instructor as a student. So I was a PT student, and I went up to Professor Ken Learman and I said, "Hey, I want to learn manual therapy. Where can I go?" And he told me to reach out to Dave. So was a student with Dave in the physical therapy world. Then he kind of got me back into that building with him and Frank Gargano at Rehabilitex, and I worked with those guys for 4 years and got me into the dry needling world. So this makes it a good connection as far as firsts. And then also introduced me to my wife.
That's right.
So you got wife, you got job, you got all the connections.
Dude, it sounds like you owe me.
One way or another. Yeah. So anyway, what we want to do is talk about how do we get people out of pain and how do we keep people moving well into the future and what's that look like. And so when you talk about body work and hands-on therapy and dry needling, Dave's the guy. Dave knows so much about that world that I guess you got to talk to him. So anyway, with that said, what before we dive in, what are you up to nowadays? What's going on? I mean, I see it from the dry needling world, but what's life in the professor world and those kinds of things?
Well, challenging these days. Every day it's something new. It's something different with, all the changes that the pandemic is bringing upon us, but it's been good. I mean, what it teaches, I think, is for our students, they're going into a world where they have to be adaptable. And, that's a skill. It's not something that people just are in a lot of circumstances. So I think that it forces you out of your comfort zone, and it kind of teaches you to get comfortable with being uncomfortable. So I think from a life, perspective, I think that there's advantages to going through something like this. But that definitely has its challenges in the academic field for sure. But it's been good. The other thing that I would say is, from a research perspective, a lot of what I've been doing has been involving dry needling, and I've had a little bit more time now to work on systematic reviews, as I've been unable to do as much of the data collection with actual research subjects. So it's kind of forced me out of my comfort zone as well in learning how to do different types of research. So it's all good though.
Yeah. How do the students do it? I mean, I think there's like half of PT school is just learning how to figure stuff out, right? So this is part of that. But how are they doing without getting the labs and the clinical? And
so we've been pretty fortunate because we've figured out different mechanisms that we've set up to still get the lab practical. It's almost felt like more hybrid than it has a traditional brick and mortar program. But I kind of like it's opened up opportunities into the current times with everything going into this, electronic world. And I think that it's forced us into this situation where now we have to take advantage of different, online platforms that are available. We predominantly use Blackboard, but you got different, Zoom conferences or WebEx or Microsoft Teams, and we've had to figure out how to use all those and which one do we like the best. They all have pros and cons to them. So we've adapted, the way that we teach, certainly. But we've been very fortunate in that COVID really hasn't impacted a lot of our students. So we've been able to kind of go at things relatively smoothly at least in this fall semester. So we've been lucky. Clinicals, you'd have to talk to our DCE, who
I don't want to.
I think all programs are facing massive challenges with quarantines and exposures and, students catching COVID and, all those types of things. But I think that, people and students are understanding that it's not going to be smooth. it's probably not going to be smooth for a while. So you better just adapt and be ready.
And I mean, that's what we're having to do in the outside world, right? Is treatment doesn't look the same. Follow-ups don't look the same. It's digital now. So
Right.
if it stays this way, at least hopefully they're ready for it and kind of go from there. But
yeah, I saw
definitely
some
crazy.
clinics are up, 45% in the number of, they're doing a lot more teletherapy.
Telehealth. Yeah, I've done a little bit of that. We do so much manual stuff that I've almost been teaching people how to do cupping, and that kind of stuff has been kind of the manual stuff we're doing. Is more like, hey, here's how you do cupping, and show you how to treat your significant other. And so just having to get creative with the telehealth, because the exercise stuff is fine, but the manual stuff is challenging online.
Yeah.
I mean, it's hard to recreate.
So, what's interesting, we did on our last practical examination for spine, we had them actually do a telehealth session where we played patient. Cool. They had to examine and do a history. But what I really liked about it was it forced the students into doing a more thorough history, because I feel like when you're face to face, they immediately want to jump into the physical examination. And we know 80% of the diagnostic process and reasoning happens in the subjective history. Yeah. So it forced them into that to be more thorough there. And then some of them actually came up with some really interesting ways of examining, like doing a cranial nerve screen over, a telehealth session.
Yeah.
Yeah. So it was cool. Like they had me like shine the light
in
front
your
of
eyes,
and they would look. Yeah. It was
That's
cool.
pretty cool. That is pretty cool. I've struggled on the telehealth visits I've done, because you're so used to, like, you want to check passive range, you just grab their arm and you move it, right? And you can't do that. So you have to think a little differently. And if you have somebody else with them, it's easier, but it still takes away some of that. But
camera angles, all that kind of stuff. Yeah.
All plays. Yep. The one I had, I was doing, a guy was like, he was having trouble walking. And so, let me see you walk. And he's off balance. And you're like, this is sketch, right? Because I'm not there to like spot, so it was kind of there's downsides to it for sure.
Oh yeah,
for sure. But we got to do what we got to do. So anyway, I guess I wanted to talk. Obviously, we both are instructors for integrative dry needling. Dry needling is a big part of what we do. I found you through the manual therapy world. What made you get into manual therapy in general, and then dry needling? Like, why those two things?
Oh man. So I would say probably back when I was a student in PT school, that really what kind of intrigued me about manual therapy was understanding the mechanisms and how it worked. Because I think that the initial impression, I guess, that we get in PT school, and I know a lot of chiropractic theories and so forth that still exist out there on this mechanical theory, reducing subluxations, those types of things that are out there. But when I started to actually research more of an evidence-based approach to how manual therapy mechanisms work, I started to understand that it's really more through the nervous system itself. And that was really intriguing to me, because I've always been kind of ortho and kind of neuro. And that's why I got into vestibular as well, is because it's kind of like the hybrid between those two. Mm-hmm. And I felt like, understanding that neurologic piece to manual therapy was just really, really interesting to me. And I used to read article after article after article about it. And it really then helped me understand how to better assess and to treat patients, using more of that manual therapy based approach. But I would definitely say it's more the neural mechanisms that intrigued me, that got me started into it. How I got into dry needling, I remember when Frank and we had this conversation. Actually, he said, there's a guy that's Dr. Ma, who is more, what's unique about Ma is, has his acupuncture background, but he also has his Ph.D. in neuroscience. And so when those two things, merge, I think it's a very powerful thing in terms of his knowledge base. And so when he said, this guy, there's a guy that wants to come and teach us how to needle people. Are you interested in that? And so my first thought was, man, I hate needles. I was actually pretty nervous about it. So like when students first come in to our classes and I ask, how many of you have ever been needle before? And some people raise their hand, but most people are pretty nervous at that initial course. And I was the exact same way. And so he's like, would you be interested in taking it? I said, yeah, I mean, I'm not going to tell Frank no. So I think I'd only been working there like a year or so. So yeah, it was pretty early on in my career. And so, so when we got into it, I remember the very first thing Dr. Ma was going through his lectures is I could tell that this was very much a neurological based approach to manual therapy, which was, from my reading and researching and so forth, even as a student, it seemed like a very sensible way to apply this intervention. So I understood a lot of it, from the get-go, just because of the neurological focus of it.
I'm going to back you up a second. Like the manual therapy and looking at the nervous system, I mean, obviously I'm on the same page with you there, but I feel like that's not the majority of therapists I talk to or meet. Like you almost have to, I don't want to say convince, but like you have to get into a discussion to get into that neurological model of how pain is interacting and how that creates guarding and things.
Yep.
I mean, where did you find that early in your career? Like, how did you get down that road? Because I feel like coming out of school, that's may or may not be emphasized.
Well, it's not. I mean, and I think that's why
and in the public, it's not.
People, most clinicians, because it's their training. It's what they're taught in school. So that can vary from different areas of the country to other areas of the country in terms of what the clinical model, that the program agrees to go by, whether it's manual therapy or exercise. There's just different philosophical approaches to it. And then there's the board exam that really doesn't test on that. It'll test on, certain principles of biomechanics like concave, convex. So a lot of programs have to cover that material for the boards. No one's going to ask really neurophysiologic questions on the board exam, even though we know that that's the primary way that manual therapy works.
Yeah, I wonder if it'll evolve to that at some point. But I remember talking to somebody who I met in a business group, and where he went to PT school, he didn't do any manual therapy. And that's a whole different conversation, but it's like, how, why, when you can have such an effect on the nervous system. But I think when people are looking at it like it's we got to change this muscle or fix this joint position. Yeah, it sounds like that doesn't make any sense. Why would we do that?
Right.
But when you talk about it from a nervous system input and how that changes patterning, now you got something. So
right.
So when you switched from, so your background is joint Maitland based, doing a lot of joint type mobilizations, and moving the joints and looking at that. When you added needling to that, or when you started getting into needling, what made it different, or what were you thinking as far as, especially early on?
I would say that I've always had that layered approach. So I've always kind of gone intra-articular assessment piece, and then working out into the peripheral tissue as well. So I'm actually not a needle first in a lot of clinical situations. I'm actually clear the joint first and then needle second. It's just my training background and so forth.
Why? Dive into that a little bit. Why joint first?
So we've had multiple conversations, not just me, you and I, but I've had these conversations with Frank, Dr. Ken Learman as well. And when you think about it, if you have a joint dysfunction, so you have stiffness in the joint, you have something, some impairment within the joint, it's going to affect other periarticular structures outside of the joint. And so if you only affect those periarticular structures and never address the joint dysfunction, then it's likely that a person's going to continue to have impaired movement. So if we can improve the joint, a lot of the times what happens then is it causes that neurophysiologic response that's created by joint movement also affects then soft tissues outside of the joint as well. So, it's that patient that can't turn their head, and you manipulate their neck, and all of a sudden they can turn freely and all the tone has gone out of the neck muscles, right? So there's that. What you do to the joint, in fact, will impact those tissue structures. But if a person though has, let's say, a chronic problem where they've had joint issues that have persisted, and now they have more long-term impact to the neuromuscular and sensory motor system, then that's somebody that potentially just treating the joint purely isn't going to give them a total relief of their condition. And so that's when then we can go to other things outside of just, trying to improve the mobility of the joint.
And what do you say to somebody, you mobilize or crack their neck and they get this new range of motion? What do you say to them, right? Because I think we would both agree that it's not you're not putting the neck back in place, you're not repositioning it or the subluxation kind of model. What would you tell that patient? What's your explanation?
I usually will tell them, I give them multiple potential scenarios, discussing with them possibilities of soreness. Some people get really sore after, some people don't get sore at all. Some people feel fine right now, they'll get sore later. And so I always give them those potential scenarios and what could happen afterwards.
But as far as why it worked, like how did that just happen? Yeah.
Yeah. So then I'll go through that whole, by moving the joints or by, manipulating the joint, it creates a stimulus to the nervous system. And that stimulus then helps to alter that input to the muscles that helps to reduce a lot of the guarding, a lot of the tension, a lot of the restriction within the tissues around the neck. So now that you can move, that's wonderful, but that's not all you have to do. And so this is where we get into that bi-directional relationship between the therapist and the patient, because if they don't move their neck into that newfound range, it's likely that they're going to get stiff again. I'm not going to say that exclusively happens with everybody, but a lot of the times it ends up where the person starts to get stiff and then they start to, have that motion loss again.
Yeah, it's interesting, right? Sometimes you get those one and done. You do something, you needle them, and boom, they're good. And it intrigues me why some people respond so much better than others. I think there's an acuity piece to it, like how new is it?
Sure.
But I also wonder sometimes if like people that have been in that pattern long enough and kind of reinforce that pattern for a long time, that I think there's a motor component to it as well, like a strategy. Sure. They're changing things. So you clear the joint, you decide to do needling. And again, I think I know where you're going to go with this, but from a needling standpoint, what are you looking for? Why needling, and why is that your soft tissue of choice?
So I think that what I like about needling is, compared to other, let's say, instrument-assisted manual therapies, is really the lesion. The depth of the neurology that you can affect, the depth of the altered microcirculation and blood flow response that you can get. And it's a lot easier on your fingers as well. So I think that clinically it's just favorable to a lot of clinicians because of the lack of, pressure and that you have to apply with it. The other thing that I like about it too is, the palpation through the needle. So when you're taking a needle through soft tissue, what that resistance feels like when it's been chronically tight for a period of time. And then when you feel it kind of let go, when you take that needle out, feeling that objective soft tissue change, I think clinically is an important piece for you as a clinician. And I think patients can feel the difference afterwards as well with it too.
As well as if it hasn't let go.
Yeah, as well as if it hasn't let go. Then you got to think, what other alternatives do I have besides, just manual needles alone? So could I use some form of needle manipulation? Could we hook some electrical stim up to it? So what other avenues do I have to address that chronic soft tissue restriction?
Yeah. And as you get more into the needling world, right, that's the big conversation is, what's the dosage need to look like? How much do we manipulate the needles? So I guess the follow-up to that is, what are your thoughts on how much of that response is, let's say, a physiological or an immune response to the lesion that you've created, versus what I simply say is some kind of neural trick, right? I put a different input into the system and now you're able to move. What do you think is true a response to the physiological damage in the repair process versus some kind of nervous system input? And how do you navigate that path with a patient?
Yeah, I'm not sure you can tell them really, because people will ask, well, how does dry needling work?
Right.
My response to them is, how much time do you have? Because in reality, you look at all the different central and peripheral mechanisms to how needling works, And, you look at Cagney's article that identified, I think, up to 15 different mechanisms to how it works. And so there's coexisting mechanisms that are happening simultaneously within the body. So to say, how do you parse these things out? I don't think you can. I think that they're just occurring within the body in general.
But would you say that you have to create a large amount of lesion? Like I had a client just yesterday, and
Okay.
I did some just basic put them in kind of needles into his shoulder. And I go to take him out, and he had needling by somebody else. And he's like, well, don't you need to get that twitch? Don't you need to like twitch it real aggressively? And I kind of quickly just said, let's see what it does. Right. And he gets up and his pain's better and we move on with our day. But how do you differentiate that response, and how much of that do you think you need?
Boy, here's where I think the key to that is, one, I don't think that there's a clear answer, because we've been studying dosage for manipulation forever and we still don't have the answer to that.
Spinal manipulation, you mean?
Yeah, spinal manipulation.
Yeah.
So when you think about what's the optimal dosage of manual therapy and or dry needling, I think it very much is patient dependent. I think if you overcook it, I think you're at just as much risk of having post-treatment guarding as you are, what was guarding them originally. So I think you got to be real careful. One of the things I know that Frank says, and I like this a lot because it's something that everybody can kind of relate to, is he'll say, 1 Advil is good, 2 Advil is better, 20 Advil is deadly. And so, there is that optimal dosage for that patient. So I think the way that you can calibrate what that is through reassessing continuously within a session to know whether or not you need to continue with higher dose, or, don't get too greedy with what you've done already, and then you end up over treating them.
Yeah, I agree. And I think you got to take into the state of that patient's health, right? Because I've had people where, you think they're going to do just fine, and then they get a hold of you the next session. They're like, man, I was sore for a couple of days.
Yep.
And I would say that I'm, fairly careful with my dosage. Like, I'm not doing anything too aggressive. So the way that immune system responds is super interesting to me. And I also think those are the people that are harder to help, because they don't, the people that are super healthy just get better, right? How do you address those people, the people that you got to be super careful with?
So sometimes you don't know right off the first session. Sometimes it's kind of a learning experience.
Mm-hmm.
But if you don't pay attention to those things, I think that you end up continuing over treating. I think those are patients that get lost, or they don't come back because, you've overdosed them too many times to where they don't think it's working. Or they feel like it might be getting worse. So
why am I paying you for this? Right. Yeah.
Right. Exactly. So, I think that when you follow up with patients and they say, okay, I was really sore afterwards, go into detail. What do you mean by that?
Yeah.
Where were you sore at? Was that soreness similar to other pain that you've experienced before? Or is this something completely new? How long did it last for? I think it's good to get an idea too of other things that maybe they had done that might have also maybe contributed to some of that. I think not moving sometimes can contribute to soreness after needling. I think just gentle movement afterwards for some patients versus other patients, more aggressive movements, they might respond better to. But I do think that sometimes when people get needled and they go home and they sit again, or they just they self-immobilize, I think that can be just as dangerous as somebody that, goes out and tries to run a half marathon later on that day. So I think that it's not just the needling alone. It's in combination with other things that they're doing that are stimulating or inhibiting normal immune system activity.
Right. Because at the end of the day, we still need their immune system. We're creating a stress or stimulus, but we need their immune system to go through that repair process. So yeah, I think that first question that you said is, how does that soreness compare to like your normal pain or whatever? That's such a big question.
Right.
And I have found myself recently, especially if somebody gets super sore, I almost do some type of like superficial or lymphatic work before or after the needles. And I think it's reducing that. So I wonder how many of those people,
So why do you think that is?
I don't know that I have enough to say like, oh, this is a thing, but I have a suspicion that there's some type of, they're having trouble clearing out inflammatory markers, or their immune system is not responding as strongly as it does. And by like doing a superficial kind of sweep first, typically I do cupping. The needles are much less sensitive because a lot of those people are sensitive to the needles.
Right.
So the needling then becomes more comfortable. And I haven't noticed the soreness afterwards. One lady in particular, I had actually treated her neck pain with needling, and she did really well, positive response. Came back with some low back pain and like a plantar fasciitis, probably a low back type of referral. But I needled a little bit in her neck because she just wanted to do a maintenance visit, like kind of just while she was there, do some needling there. And then I did her back and her, kind of followed that nerve distribution down the leg, and it like wrecked her. Like she was like sore, like flu-y like for a few days. And she's somebody who I had needled, but just kind of, I think because we did multiple locations, the dosage got higher.
Right.
So I followed that following visit with literally just cupping the entire system. Didn't do any needles the next visit. And soreness, whatever fatigue she had was completely gone afterwards. Interestingly, her back and her neck were also a bit better. And then we got back into needling on that third visit, and didn't get that soreness again, which I was more careful with my dosage. But I don't know if that's a lymphatic thing, if that's a circulation issue, a sensory nerve guarding aspect that you're kind of hitting with some of the sensory nerves with the cupping a little more heavy.
Well, and we know, all these things are related to one another, and so it's not like it's one system. It's oftentimes the interplay amongst multiple systems.
Yeah. I wonder, like, I'm very interested in the sympathetic nervous system activity. And if the sympathetic nervous system is causing, so that stress kind of nervous system, fight or flight, if that guarding the pain protection, let's say, of that muscular tone around a joint, could that also be constricting some of the blood vessels in the area so that we're not getting the clearance we want? And so do we need to work on some of the superficial and maybe sympathetic inputs from the skin and some of the superficial vessels? From a nervous system standpoint, I could see how it would restrict that as well, not just some of the deeper tone that we think of.
Right. And I think that when we talk about needling or manual therapy, it's not that it increases or decreases this nervous system activity or sympathetic activity. It helps to normalize it. And that's an important point, because it really depends on the state of where a person is in terms of that sympathetic output. So, does it create parasympathetic activity or sympathetic activity? It depends, right? It depends on the state of that person. So I think then that ties into okay, what about the emotional component? Where's the patient at emotionally with life or with stresses or whatever? Because I think that all of that,
even the treatment, like how do they perceive that treatment session? Like, is it going to be helpful or not? How nervous are they about needles or cups?
Yep.
Yeah. I mean, all. Yeah. That's
needling anxiety. It's a real thing.
Yeah.
You
live that one.
Real thing.
Yeah. It's interesting. Yeah. Which does it do? You get the same question in courses all the time of, does it activate a muscle or turn off a muscle?
Yeah.
And I don't know. I know people want an answer, but I don't understand why we think we have so much control over how the person's going to respond. Like, I'm going to put a piece of tape and it's going to activate the muscle, or I'm going to put a needle and it's, I mean, you're just trying to provide an input and hope that the system responds. But I think you got to think about it so deep that people don't love it,
And the other side of it is it's not up to you.
Right. Right. You don't get to do that.
You're just providing, like you said, you're just providing a stimulus. It's not up to you how it's going to respond. So you can put the piece of tape however you want. That doesn't mean that you're going to get the response that you actually think.
Right. And then people want to call it a placebo, right? Because you say, oh, they just think they're going to get better. What is your response to that question? I know what mine is.
People have this idea that placebo is a bad thing, and I don't understand why. Like, placebo is a good thing. There's certain in the area of research. Okay, we want to know why things are working, but there are certain things that we cannot control for. And in manual therapy research, it is really hard to control for placebo. And we know that it exists pretty much in everything that we do. So you have to account for it to some degree in your effect size of these, you know, RCTs and so forth. But to me, it's not a negative thing. It's if somebody gets, you know, manipulated and they get the audible and they have better range of motion because they got the audible versus if they didn't get an audible, you know, does it matter? They have better range of motion. You know what I mean? So from clinical practice, I don't think placebo is a bad thing at all. In research, I think it's one of those things that you try to control for as best as you can, and don't overemphasize the impact of your treatment on the patient outcomes, because you don't want to say, well, you know, my manipulation was that much better. Well, how much, you know, are you accounting for the placebo effect of that manipulation or whatever? But yeah, I don't think it's a bad thing at all. I think that what's worse is the nocebo. I think when you use catastrophization of patients, you know, you show them an image and you say, well, I've never seen, you know, a spine that looked that bad, or a knee that looked that bad, or arthritis that looked that bad. All that stuff is aging. I don't get why, you know, they have to use, you know, normal degenerative problems as a way to catastrophize patients, because we know that there's a ton of people that are walking around that have arthritis and have degenerative changes in their spine or in their peripheral joints, and it's normal.
Yeah. It doesn't make any sense to me. I've seen some MRIs. I just had a guy who is a friend of a friend, and he showed me his MRI, and I was like, okay. And I was like, how you doing? He goes, I don't have any pain. And I'm like, what? Like, I'm looking at this MRI going, it's bad. Like, there's multiple herniations. Part of the disc is ruptured and kind of floating up. And I'm like, that doesn't look good. And he's like, I don't have any pain. I got a little bit of numbness in my leg, and that's it. I'm like, you know,
Yeah, that's good.
good for you, man. But yeah, I mean, I don't know. I had a guy who.
So, listen, I had a guy who, obviously I'm not going to mention any identifiers, but he was mowing his yard and a tree fell on him, like,
yeah, big tree
across his lap. And he had multiple fractures, severed his femoral artery. I mean, just lots of bad things that happened.
Jeez.
Minimal pain. Complete sensory.
He had a
There's
sensation.
no sensory involvement at all.
Acutely, he had no pain, or like months later.
Well, acutely, he was in shock. But once he got through that part of it, yeah, I mean, by the time I saw him in outpatient, he's like minimal pain, if any. He goes, I'm just glad I'm alive. I think that, you know, people's perspective is important, you know, in terms of their experience with pain. But
yeah, because it's all on how you think about it. Like, people that get in a car accident, like, you treat somebody that they caused the accident versus somebody that got hit and somebody else hurt them. The outcomes are different. I don't know what the research is, but the outcomes are different. Like, it is definitely harder working with somebody that got hit versus somebody that wrecked their car into somebody else or hit a tree. I mean,
there's the notion of the victim, you know, in a situation.
It changes that perception. Now, do you think, so the emotional side, the cognitive side of that is obviously super important. Do you think manual therapy can have a role in the emotional side of it?
Absolutely. The same areas of your brain that process pain are those that process emotion.
Right.
And so that's why, you know, chicken or egg scenario, people that have chronic pain oftentimes have anxiety, depression, emotional disturbances of some sort. And so we don't know, is it the changes in the brain due to the chronic pain that start to facilitate those depressive thoughts, or is it vice versa? Do these people already have depression and anxiety, then they get injured, and then they develop this chronic pain, you know, experience due to the already existing depressive behavior that they had. So I do think that if you could, that's why I think, you know, looking at cognitive behavioral therapy and trying to have patients focus and rehabilitate the emotional component, it oftentimes helps their pain too.
Yeah. Yeah, I agree with you. I don't know that we completely understand that mechanism, but I mentioned to you the other day that cellular pathways of how the different, you know, you're looking at activation of different cellular pathways in the brain and how they relate to chronic pain and also neurodegenerative diseases, whether that's an inflammatory thing or some type of a protein type. I think that's the future where we're going to see medicine or healthcare, I should say, where we're going to see it go.
I agree.
It's a deeper level understanding, but we can measure those things now. So, you know, we got to figure out exactly how we can interact with that. So that's cool stuff. What else, man? Anything else you want to say was in regards to dry needling and what you've been doing from a research standpoint?
So we are, right now, we're over 50% through the data collection for our headache trial, which is a cool one because we're taking people who have cervicogenic headaches, and they basically get randomized to either dry needling, cervical cranial dry needling, or they get randomized to orthopedic manual therapy to the neck. So with the dry needling group, essentially what they have done is it's semi-standardized in that they get upper cervical needling from C1 to C4, and then they get 30 seconds of needle rotations in those paraspinal points. And then the clinician can also needle any potential muscular points that they feel are indicated, whether it's the sternocleidomastoid or the scalenes or the upper trap. And they can also then needle the headache distribution pattern. So if it's a trigeminal headache, they can come and needle, innervation points of the trigeminal nerve. If it's more greater occipital, they can stay back on the posterior fossa. So they can be very specific to the headache distribution that a person has.
Is there a dosage limit? Like how many needles? No, the clinician decided.
What we are recording on the first visit is the number of twitch responses that a person would get with a patient, just to see if there's a difference depending on the number of twitches that they get.
And that's clinician sees the twitch?
Yeah, we're not using ultrasound just because I haven't had consistent access to an ultrasound machine until now. So
I'll say I have one. I don't know that I can see anything, but I have one. I still need some practice. It's, when somebody puts it on the screen, you're like, oh yeah, I see it. But manipulating that thing to get the image you want is, I know where I'm at, but I don't know that I'm good enough to be like, oh, that's this, or that's a tear, or that's a pathology. That's normal. That I'm not good enough yet. So
right.
More
and,
courses.
The other interesting thing about, in the area of myofascial trigger points, we oftentimes will use images of that local foci within the skeletal muscle tissue. And so I ran this by a person that does they have about 25 years in ultrasound diagnostic experience. And they're like, you have no idea that's what that is. Like, okay, fair enough.
Yeah.
He goes, that's a theory. That has not been validated to actually be true.
Interesting.
Yeah.
Interesting. Yeah. I mean, I think I just did our ultrasound needling course. I think I could identify tendons, and to be able to needle a tendon, I'm pretty confident that I could do that. But what you're saying, like those kind of details, I have no idea. But anyway, so you're needling upper cervical, and then clinician selected points. And then where are you guys going from there?
So then the other group that gets the manual therapy, they get either mobilized or manipulated, clinician choice. They can target whatever level they want to target based on, the symptomatic area of the neck that's generating the headache. And then in terms of the dosage, it's totally up to them.
How about soft tissue? Are they allowed to do cupping, instrument assisted, any kind of?
No, just to try to minimize the interplay between any, soft tissue manipulation and the joint mobilization manipulation. And so the idea is that really what we wanted to do with this is take guideline-based care. So the American Physical Therapy Association's orthopedic section published guidelines for different cervical pain conditions, one of them being a cervicogenic headache. And so I always tell people that when that was revised, when I was looking through the recommendations for the different cervical pathologies, some of them did include dry needling, but cervicogenic headache did not. And I remember thinking to myself, that's kind of wild to me, because in my clinical practice, anecdotal, but headaches I feel like is like needling's pretty big with migraines and cervicogenic headaches and so forth. and tension type headaches. So I was kind of like, wow, that's interesting. So let's do a trial to compare those two things. So then basically the one group gets guideline-based care, and then the other group gets mostly guideline-based care, but they get needling instead of the orthopedic manual therapy to the neck.
Interesting. Yeah, that surprised me when you just said that. Like that classic like ram's horn cervicogenic headache, like if they don't leave 50% better or better, I'm kind of surprised.
Right.
Like if they walk into the clinic with a headache, I'm going to be able to change it.
Right.
Most of the time. How about exercise? Is it like a standard exercise program?
So it's not standardized. So
that's what you did with the low back one, right?
Yes. To try to minimize the fluctuation in how people could apply back exercises, we standardized it in that one. This one, because we already know what basically the effect is of exercise for the neck, we gave 10 options of different exercises, and then the clinician can pick 5 of them.
Oh, okay, that's cool.
So we didn't want to say we have to do these things because, they might want to do a different, direction of exercise. So we allowed them some flexibility to do that. The other cool thing though, with this is that they're also getting a rescue technique. So they will be prescribed a headache relief technique, like a Mulligan snag, like a C1-2 snag, or the headache nag. So they can get a specific relief exercise for their headache, which hasn't been done yet.
Interesting. When you say it hasn't been done, like as part of a study or just?
As part of a study. They haven't really looked at the impact of patients being able to symptom manage their own headaches over the course of time beyond discharge. So our study, we collect data up to a month as they're receiving treatment. Mm-hmm. After 1 month, they're no longer getting treatment. We're going to follow up with them again at 3 months and then again at 12 months. So it'll be interesting to see what the outcomes are for these patients who are doing their symptom management techniques, if they're doing their symptom management techniques. Yeah.
I mean, I've had patients that have been doing those for years, right? Where you're talking like towel snags or that nag. Yeah. So that's cool. I like that. And it very closely now resembles what you would do, right? Whether you decide to needle or not is one thing, but the rest of it sounds pretty consistent. So that's a cool study. Is it twice a week?
Yeah.
Twice a week for a month?
They go 2 times a week for 2 weeks, and then they go 1 time a week following that for the following 2 weeks.
Sounds pretty sweet.
So I leave that up to the clinician as well.
Yeah. When do you think you'll be done with data collection? Yay for COVID.
Yeah, COVID, I would already be I would say within the next 6 months or so, I should be
cool.
6 months to a year.
Yeah. Crazy process, all that research stuff.
It's fun. I mean, it's pragmatic, and that's what I like about it. Mm-hmm. Is I've always tried to make my research projects meaningful to practitioners and not do something that's, purely within a petri dish type of situation where if you put it out, if you take that information and it doesn't alter clinical practice in some way, what's the point?
Yeah. No, I like your study designs because you let the clinician make some decisions. Because it's really hard to, like, you can't eliminate all the variables and where you want to needle or where you, like, if you just gave me 4 points and said, do this, well, now what if this one little thing is different?
Right.
I can't do anything about it. So in my head, I go, well, yeah, that's a cool study, but I would have done it different anyway, So this way you're getting to see how those clinicians are going to make decisions, which is, it's going to be huge.
It's more generalizable to practice, but
right. You could actually use it. Yeah, that's cool. All right, man. Well, this was fun. And before we wrap up, anything what's your interest? What are you into? Anything that's going crazy that you're like super interested in right now?
Professionally?
Or personally?
Oh man. What's going to be interesting, I think, in PT here is I feel like we're at a crossroads of our professional identity. I think that what happens in the next 5 to 10 years is going to be interesting in our profession because we are trying to go that primary care route. And some states are pushing harder for direct access and more accessibility to direct access patients. So it'll be interesting to kind of see that, because I also feel like we are at we're trying to figure out what is our role within this massive healthcare system. You know, we have so many different hats that we can wear in different areas. I feel like we're trying to figure out that true professional identity at the same time that we're trying to figure out what our role is in the system itself. So I think it'll be really interesting to kind of see how this plays out in the next 5 to 10 years. And I also think that, you know, the proliferation of so many PT programs is also going to impact this as well, because you got, you know, some hybrid programs that are out there that are taking, you know, big cohorts, you know, and where are all these people going to be working? What are they going to be doing? If we meet that primary care role, I think it'll expand opportunities for these students to, you know, once they get out licensed, then they can do it. But it'll be interesting kind of how all of these things come to fruition here for us.
Yeah, that's I guess that's something I don't think about all that often, right? I've kind of taken on that primary care role, being direct access, and
right,
99% of my people see me before they see their doc. That's just kind of the way it works. And I think there's a huge benefit to that, because we're able to skip some of the sometimes not needed medical steps of, you got to go get this x-ray, and then you got to go do this, and then you got to go see this person, and then you got to go see that person, and then you got to go see this person. For mechanical pain, we're able to kind of triage that pretty quick.
Right.
And make those decisions of, hey, I can't triage this, now we need to refer out. But right. If you start with your primary care, a lot of times it's X number of weeks of rest, then maybe you get to a PT, but maybe you get to some other specialist. And so I think there's a huge avenue for rehab specialists to take on that primary care role. But I can also see, you know, why there would be some resistance to that, I guess. And from a reimbursement standpoint, that's a whole nother beast. You know, are you gonna pay PTs enough to get good at primary care rehab? Yeah, I mean, are they gonna spend enough time to get good at it?
Yep. Yeah, it'll be interesting. Did you see that article that was published in JOSPT recently that was looking at the cost impact of direct access?
Yeah.
I mean, clearly early PT, I mean, this is another study that shows that early physical therapy reduces cost, not just on the patient, but on the system.
Do you remember the numbers? I don't remember them off the top of my head.
No, I just actually.
I just looked at the abstract.
That's what I was looking at this morning. So I'm going to look at it more thoroughly here, but yeah, interesting stuff though.
Yeah, that's cool. All right, man. Well, hopefully this actually recorded and we can use it.
It says it's recording.
It says it's recording, as long as the sound's good. I tested it earlier today, but you know how that goes. Yeah. So anyway, thanks, man. I appreciate it. We'll have to.
Yeah, we can. If you want to redo anything, just let me know.